very excited for this webinar. We have a set of great speakers today that will be talking about developing and validating ways to model high-dimensional data. And just a reminder, this toolkit was put together, this webinar is put together by the National Clinical and Translational Sciences Life Course Enterprise Committee, and on behalf of the Lifespan Domain Lifespan Enterprise Committee, we are happy to bring you this webinar. Our first speaker today will be Dr. Sandro Galea. He's a physician and epidemiologist and the Dean and Professor at the Boston University School of Public Health. Dr. Galea is centrally interested in the social production of health of urban populations with a focus on the causes of brain disorders, particularly common mood anxiety disorders and substance abuse. He has long had a particular interest in the consequences of mass trauma and conflict worldwide, including results from September 11 attacks, Hurricane Katrina, conflicts in sub-Saharan Africa, and the wars in Iraq and Afghanistan. So Dr. Galea, we are very excited to have you here with us presenting on high-dimensional data and life course research, and we will turn it over to you.
Thank you very much. Thank you to the CTSI and the Lifespan Enterprise Committee for inviting me. So I was asked to speak about understanding health across the life course at a high level and to point out ways in which data would need to be understood towards informing us how health is produced over the life course. So I want to start with a couple of comments about how to understand population health, broadly speaking. And I'm going to do that by showing a cartoon to start. It's a cartoon from On a Plate, which is a series from New Zealand. And this is, the way to follow this is two panels, panel on the left, panel on the right. And it says on the left, this is Richard, his parents are doing okay. This is Paula, her parents not so much. Richard's house is warm and dry, shelves are full of books, fridge is full of food, Paula's house is full of people, damp and noisy, keeps getting sick. Richard's parents will do anything for their child, and so will Paula's. That's why they're working two jobs. Now, Richard goes to a great school, his teachers love their job. Paula's school, the classes are large and underfunded. So we can see why expectations for Richard, where his parents say B+, we need to get you a tutor, are different than those set for Paula. B, hey, that's not bad. And over time, of course, Richard's parents are paying for university. Paula's working and juggling her polytech and getting in debt. His dad puts in a good word for him, gets him an internship while her dad is sick. And each little difference sneaks by unnoticed. His loan is approved, her loan is not approved. And Richard starts to believe that he's achieved what he's achieved by his own success. There's this cartoon that says, Roger's boy, right? I'm keeping an eye on you. And then we see a party, which is where Richard is being congratulated for some achievement, for which no doubt he worked very hard. And Paula is now serving food. And Richard says, the secret to success is less whining, more hard work. I'm sick of people asking for handouts. No one ever handed me anything on a plate, which of course she is. Now, why am I showing you this? I'm showing you this because anybody watching this webinar will recognize that this is all entirely true, entirely right. But it really makes the case, I think, this cartoon, about how advantage accumulates over a life course, how small little piece of advantage right from the beginning that fundamentally are advantages of the luck of the lottery at birth. It really had nothing to do with anything Richard achieved. There are many metaphors on this. It's like sort of starting from second base, third base. And that doesn't obviate the fact that Richard did a lot of hard work. It doesn't obviate his own individual behavior. It simply says that we cannot understand his behavior, his achievement, without understanding his whole life course. And similarly, we cannot understand the health of Richard and Paula over time without understanding their whole life course. So I think this perspective, a life course perspective, is foundational to understanding health in populations. When I go now to populations, I'm going to go to a schematic. If one thinks of a population like this as a series of these gray figures, what we're trying to do from a health perspective is understand health in populations, which are the dark blue figures here. And we really are trying to understand health populations and how that health is generated over the life course. And we want to understand that so that we can actually make some people who might be sick healthy, prevent them from getting sick. This is a different approach than an approach that focuses only on a subset of people who are typically patients in a clinical setting. So we are trying to understand health over time in whole populations. When one thinks of it that way, from my perspective, there are two core conceptual framings that we need to think about the production of health in populations, which I think inform then what data we get and how data lends itself to answering these questions. Those are a life course perspective and an eco-social perspective. A life course perspective might look something like this. This is modified from a paper. But what it says is you have age here, and then here you have development of poor health. Different stages in life, prenatal, infancy, adolescence, adult life, older age, result in accumulated risk. In prenatal, it's mother's nutrition, mother's access to care. In infancy, separation from parents, exposure to violence. Adolescence, social support, discrimination. In adult life, employment conditions. Older age, social isolation. Genetics do matter. They continue to matter at a baseline level. They don't really change much over time. But fundamentally, we accumulate risk over the life course, just as Richard and Paula accumulated their life circumstances over the life course. So that's model one. And I think when we apply data to understanding this, we need to apply data ideally at all of these stages over time to understand health. The eco-social framework tells us it's not just about me. It's not just about how I progress over time, but it's also about the world around me, because my health is influenced, yes, by my genes and by my behaviors, but those are influenced by my social relationships, my living conditions, my neighborhood where I live in, the institutions I live in, the social and economic policies. So this is quite a tall order for data to come to inform a life course perspective and an eco-social perspective. But once you understand this, that this is what causes population health, it becomes difficult to see how we can understand population health without applying data to understand both the life course perspective and an eco-social perspective. Now, what I wanted to do is very quickly, in a couple of minutes each, talk about 4 key concepts that I think emerge naturally from the understanding of health being produced by the life course, being produced through an eco-social framework, and us needing data to inform all of these all of our understanding of population health. Now, I'm picking 4 concepts. I could pick many, but I think these concepts are central, and they are central to how we analyze data and how we think of and understand population health. Number 1, population health and the data used towards it are continuous and not binary. Now, this sounds obvious. It's perhaps the most obvious of all principles, but I think it's critical because in health, far too often we think dichotomously. We tend to think of health as being sick or not sick, binary. But health is continuous, particularly in populations. There's a classic population normal curve looking at distribution of body mass index. And all I want to show you here is the distribution of body mass index, which is exactly as you would expect it. And then the cutoff, a BMI cutoff at 30. If we are looking only at the prevalence of people who are obese, we're looking over 30. If we look at the whole population distribution, that is quite a different picture. And in fact, when we look at how the country's weight has been evolving, I want to show you the data from NHANES national survey in 30 years ago, I guess 40 years ago now, and then just 10 years ago. And what you see is this shift in the population distribution. So while we frequently talk about obesity being to the right of the line, which I realize has been shifted a little bit on my slide, and we talk about the increase in the absolute prevalence of obesity, which certainly you have here, pretty increase in prevalence, but the whole population has shifted in that everybody now carries a little bit more weight, which of course, all of that accumulates risk over the life course. And a life course perspective says that we want to take data that follows things over time so that we can actually understand how those pieces fit together and result in this shift of distribution over populations. And this, of course, informs how we may intervene to improve population health. Because if you take an approach that looks only at dichotomies, you can take what Jeffrey Rose called a high-risk approach, which means you take an approach where you simply intervene for people who beat the cutoff. A population approach that recognizes the production of health over the life course and recognizes the eco-social forces that bring health to a fore in individuals as part of populations will then ask, how can we intervene, not just at the individual level, but also at the social network level, at the neighborhood level, the community level, at the policy level, to shift whole populations, to shift the distribution. And that is only visible when you realize that data are distributed in populations continuously. That's point A. Point B, if we are to look at distribution of data across populations informed by a life course and eco-social perspective, we need to understand that many of the causes that we're interested in are ubiquitous and often invisible. I want to show you one concrete example of this. This is in the mid-80s, there was a lot of talk about crack babies all the time, which is moms who used cocaine while they were pregnant and then the consequences for their children. And of course, there was there's a lot of talk about that, but eventually studies emerged that actually showed that over time, there wasn't much difference between the children who had gestational cocaine exposure and control, that's the gray versus the white, on developmental metrics, despite the fact there was a lot of talk about how this may affect these children. Further studies are done and showed that the reason there was no difference is because there was a difference in these babies, but it wasn't due to gestational cocaine exposure. It was because of environmental stimulation, that these babies were all born into poor environments and really stimulation poor, not just acid poor, resource poor, which was a ubiquitous factor. That's what shifted their curve. They were predisposed to be doing poorly. They were being set up by their life course to do poorly. And our data needs to capture that. If we only focus on gestational cocaine exposure and the outcome, we are going to miss much more important things, which is the overall context within which these babies were born. I could tell you a more concrete example. We talked about the shift in our obesity, which is of course a central risk factor for non-communicable disease. And we could talk about what is more ubiquitous now, which is more calories in our environment. Bagels used to have 140 calories. Now they have 350 calories. Plate of pasta used to have 500 calories. Now it has 1,000 calories, etc. This is the ubiquitous force around us that over time, over the life course, accumulates in the generation of the health of populations. Point three, predicting populations, not individuals. We are in the middle of right now as we're taping this of the COVID pandemic. There's been a lot of talk about predicting what happens. It's very difficult to predict what happens to individuals. We're much better at predicting what can happen to populations. And that is a simple function of population level data and our statistical tools. And that of course has real implications for then understanding that when we're talking about life course, we are trying to predict life course population health, not life course individual health. I'm going to show you this from a paper published in the Framingham study, which is run by my institution. This looks simply at the cumulative incidence of diabetes and genotype score. And what you see here is that the higher genotype score, the more diabetes there is in the population. When you see something like this, your inclination is to say, well, I wonder what my genotype score is. I wonder where I fit in the likelihood of diabetes. But of course, this is a population level observation. You can also take that same data, look at the same genotype score, and look at people with and without diabetes. And what you see here is that the curves of people with and without diabetes very much overlap. So at the population level, while a genotype score of 18 may mean people are much more likely to have diabetes than not, at the individual level, knowing you have a genotype score of 18 doesn't really change very much, does it? And that is very much a fundamental reflection of how data can be used at the population level and how it becomes very difficult to discriminate at the individual level simply because the production of health at the individual level is highly complex and involves full sets of variables that are often beyond the scope of what we're looking at any one point in time. So prediction is much more useful at the population level than at the individual level. And the fourth point at the population level, thinking about life course perspective on our health, is that we need to be thinking about health overall and health gaps. And often there are trade-offs between overall health and health gaps. And if we're going to be thinking about applying tools to understanding the health of populations, we should have the wisdom to recognize that those tools are telling us things about overall health achievement and less, or perhaps something different, about health gaps. This is simply a reminder about the widening income-related inequalities that we have in this country at the moment. This looks at birth cohorts of people born 1930, people born 1960. This looks at what the life expectancy was at for the poorest quintile versus richest quintile then, and then for people born 1960s. Now there's a 13-year gap, people born 1960s, while there was only a 5-year gap, people born 1930s. So inequality in our health is growing. It is a central feature of the health of our population in this country. And to my mind, it's one of the biggest challenges that we need to face in health. However, it is important to remember that that has to be considered in concert with overall population health. And the two frequently are jarringly in juxtaposition and may even be in contradiction. Inequality among women. Only the richest quintile of women have actually gained in life expectancy in the past 40 years, while the poorest 80% of women have not gained. All really making the case for the importance of inequality. But now let's think about how we can improve inequality, how we can improve overall health. Supposing we have a situation where you have, in a no intervention situation, you have an inequality of 25 DALYs, that's disability adjusted life years. Suppose you intervene in such a way that that you get 1 DALY per 50. That's not unreasonable. You create an exercise program where people, of course, who are already in reasonable shape can now exercise. While people are in poor shape, they can exercise a little bit less. You can improve overall health, as you can see, the average here is greater than it is here, but you've widened inequality. Look at another version where you're adding 10 now. You have 10 here, you're adding 5 here. You've improved overall, but you've increased your inequality. Let's talk about another example. Suppose before the intervention, things were equal. Well, you can intervene in a way that people who have more access to power, wealth, and resources are more likely to get the intervention, which is always what happens. This is why we have things like digital gaps. This is why we have things like intervention gaps. Overall, we may have improved population health, but we may have resulted in more widening of health gap. Now, I'm not saying this is good or bad. I'm not saying this is right or wrong. I'm simply saying that these are realities of how health is produced over the life course, and a data-intensive approach, which is what we should be taking, needs to recognize both overall health and health inequities in order for us to be able to inform society in making difficult decisions. I'm going to stop here, and I'm going to conclude with just this one slide. This is a picture of my pet goldfish, and the reason I show you this is because when we think about the goldfish's health, we may think about telling the goldfish to exercise, to swim around its bowl 10 times clockwise, 10 times counterclockwise every day. We may ask it not to eat too much food, to be careful for its weight, to reduce its risk factors for chronic disease. And all of that may be fine, but unless we think about the goldfish's water, the goldfish is never really going to be healthy. Health produced over the life course across multiple levels is an example of the goldfish in the water bowl and why we need to think about the water. And I think that is why I was glad to be part of this, because anything that highlights thinking about life course in multiple dimensions, multiple levels of influence, and then applying data and methods to understand data so we can understand the production of health in that vein is going to be a positive for our capacity to understand population health. Thank you very much for having me.
Thank you, Dr. Galea. That was a fantastic presentation. I really like the point that you made there at the very end about inequalities in interventions. And it's something that I've been thinking a lot about, especially when you think about what populations actually have access to smartphones or internet. And a lot of the interventions that are coming out right now that are really cool involve some sort of access to that technology. Are there ways that we should be thinking about designing those interventions, or do you have any recommendations for kind of dealing with the inequality in interventions?
Yeah, if I may adapt something that Julian Tudor Hart wrote like 50 years ago, the inverse care law said the people who need care less are the ones who are more likely to get it. One could extend that to say the people who need the intervention less are the ones who are more likely to get it, because you are more likely to get the intervention if you have access to the resources that keep you healthy to begin with. So I say that by way of saying that the only way, Heidi, to achieve what you're asking is by being deliberate and intentional about it. Anything that we do that simply says, we're going to create an intervention and make it democratically available, by definition, that means it's going to accrue to people who already have the assets and the resources and who need it less. And by definition, it's going to widen gaps. So the only way to really make sure that an intervention doesn't contribute to widening of gaps is by being explicit in developing the intervention in a way that it privileges those who are less likely to get it to begin with.
That's an excellent point. Thank you. I'm going to turn it over now. Dr. Jomi Ramsey is moderating, and she will be asking other questions that have come in. I'm just going to remind everybody to please enter your questions in the Q&A section of the Zoom, and we will answer as many as we can, and those that we cannot answer, we will answer live or address at a later time. So Dr. Ramsey, I will let you field the questions now. Thank you.
Thank you. So the first question we had coming in was, how can we capture this context in secondary data analyses and incorporate it into our research? Are there ways to do this when we're looking at EA groups and data?
Yeah, so thank you for the question. I think the answer is there are always ways, even if they're never quite as good as we'd like them to be. But fundamentally, the way to do it is either by combining data sets, by being able to merge data sets with other data sets that give you elements of context. And also there are more and more systems that are collecting data that characterize context. Now, I think we're having more capacity to assess context in different environments. I think different systems are collecting some type of context data. So I do think that all hope is not lost on this. And the premise behind this seminar is to think about high dimensional data, complex data, that can lend itself to answering these questions. And it's not simply a matter of getting the data, it's also a matter of then thinking of how to analyze the data and to incorporate into what I'm saying. I quite like the setup here that I was speaking at a high level, and then Professor Gianfrancesco is going to speak after me and talk more about the methods, because of course, it's not just our data that are lacking in characterizing the fairly aspirational tall order that I put out in front of us, but also our methods not infrequently fall short. So the answer is, I think one does what one can. And I suppose the purpose and the point of laying out a conceptual underpinning is to help give us a lodestar, a direction in which we are headed.
Thank you. So on a related note, what social and environmental variables do you feel should be collected in our data sets to better address this?
Well, I think it depends very much on the question. And I think one of the challenges with thinking about data at multiple levels over multiple points in life course is that it becomes all data about everything all the time. And of course, that is both overwhelming and fundamentally impossible to weed through it. Now, of course, you can use artificial intelligence approaches, things like machine learning, to help weed through data. But I think we have to be careful that there's quite a bit written about things like the exposome, which really is about all levels of data at multiple levels. I often worry that that kind of thinking is indiscriminate about saying lots of data, all sorts of data all the time. And I don't think that that necessarily means that we need all data all the time. So I think it depends on the question. It depends on why we think that particular data are available, might have utility, and applying the data to address causal chains that are relevant to the question.
Thank you. So another question was, high quality data does not have equal coverage over global populations. How can we avoid focusing only on populations or interventions where data is readily available?
Yeah, it's a terrific question. This is the lamppost bias, which I often use in my talk. I presume that the questioner is referring to this. Lamppost bias, very quickly, is you see somebody on their knees in the dark under a lamppost where there's light, looking for their keys, and you say, what are you doing? They say, looking for their keys, and you help them. You bend down with them, look for their keys. A few minutes later, you don't find their keys, and you say, well, I don't see your keys. And they say, well, no, I didn't lose them over here. I lost them over there. And you ask, well, why aren't you looking over there? I say, well, but there's no light over there. So ultimately in science, we often end up looking where there is light. Now, it's a very natural impulse, and I've done it myself. I suspect everybody on this seminar has done it themselves in their work. And I don't have an answer as how one avoids it other than being aware of it. I actually value the question because I think the question says we are aware of it, and can we push forward with approaches that mitigate that particular challenge? In other words, can we avoid looking for our keys just where the light is and saying, no, our keys were lost over there, AKA the question is over there. Let us use even imperfect data to address the question we want to answer, rather than addressing a question just because it's convenient.
Thank you. So I think we have time for one last question. So focusing again on interventions, the same interventions that work for higher SES often don't work with lower SES populations where environmental and social context drive health outcomes, even when individual behavior change is achieved. What is a realistic way to address this?
Yeah, I think it's an excellent question. And I think and frankly, I think it's the right question. I think the realistic way to address it, first of all, is by having interventions that would work in particular contexts and being aware that one size does not fit all. I think in the global context, which some of the questions have hinted at, is one of the mistakes that we've often made in implementation science, is saying, well, something works in a high-income context, let's just adapt it for low-income context, when in fact, that may not work at all. And the reason it may not work is simply because the life course context and the multi-level ecosocial context is so different as to obviate the utility of that one particular variable. So I think the way to address it is by being aware of that and by tailoring interventions, taking into account the full life course and ecosocial context within which a particular intervention is intended to have its effect.
Thank you. So I think that's all the questions we have time for. So I'm going to turn it back over to Dr. Hansen to introduce our next speaker.
Thank you.
Thank you again, Dr. Galea. I appreciated your presentation, but the answers to your questions were fantastic. And I really like the way that you pointed out our need to be aware of our own biases and the ways that the way that we're thinking about our research and planning for our interventions may bias outcomes later on down the road. So thank you very much for your time.
Thank you.
All right, we are going to go to our next presentation. Dr. Milena Gianfrancesco will be talking to us about how we actually implement some of this research and incorporate many variables in our high dimensional data questions. And she is an assistant professor of medicine at the University of San Francisco. Her research is focused on examining the causal effect of sociodemographic and genetic factors on patient safety outcomes in individuals prescribed with high risk immunosuppressive medications. We are excited to hear a little bit more about her research and how she's actually applying some of the things that Dr. Galea raised in his talk. So Dr. Gianfrancesco, we will turn it over to you. Thank you.
Thank you for the opportunity to present today, and thank you to Dr. Galea for his wonderful presentation, which I think will touch on a lot of the different aspects that he spoke about. Oops, okay, sorry. So today in this talk, I'm going to discuss modeling high dimensional data, or a lot of people refer to this as big data lately, and the corresponding statistical methods that are best suited to analyze these data sets. We'll cover how machine learning techniques are powerful, informative, and have the potential to shape the future of healthcare, but also discuss how they're not immune to bias. And acknowledging these limitations is really important to the integrity of the research being conducted. And throughout the talk, I'll also highlight how including factors such as social determinants of health are essential in understanding disease complexity. Big data has received a lot of attention recently, especially in the healthcare space, and it's usually described in terms of 4 Bs. Volume, relating to the amount of data collected; variety, in the different types of data collected; velocity, the speed at which data are collected; and veracity, which is ensuring the accuracy and quality of the data, which I would argue is the most important, but often the most difficult. And the goal of big data is to discover associations and understand the patterns in the data. And the hope is to really inform the physician and patient during the decision-making process to help determine the most appropriate treatment option for that particular patient. So how can we best harness this high dimensional or big data to inform our understanding of the disease process? We'll discuss 3 different areas. The first is instrumental variables to measure the causal effect of exposures on disease risk. And we heard a little bit about genetic risk scores from Dr. Galea in the population context. And then we'll talk about machine learning to classify subgroups of disease and predict outcomes. And lastly, understanding potential biases inherent in different data sets. And I'll also note that my focus of study is on autoimmune diseases, and so many of my examples are going to include these conditions, but the methods can easily be applied to study several other types of chronic diseases, and actually come from literature on other chronic diseases. So first, let's dive into instrumental variables. So most health-related studies aim to answer causal rather than associative questions. We want to ask, what is the effect of drug X on outcome Y? But traditional statistical analyses usually only examine associations, looking at the association between X and Y controlling for W. But there are study designs and methods that appropriately address confounding and allow us to measure the causal effects. We usually consider randomized controlled trials the gold standard for study design examining causal effects, but we need to remember that they're not always possible, they're expensive, they're not always representative, and randomization answers our primary outcome only, and if we're examining a different outcome from the data, this randomization is broken. And there's been a lot of recent attention lately in using observational data to simulate or emulate randomized controlled trials using more representative data sets. So there are statistical methods to assess causal effects with observational data, and these include instrumental variables, a subset of which is Mendelian randomization. There's G computation, inverse probability weighting, and several other different types. But today we're going to focus on instrumental variables, specifically Mendelian randomization, which is basically instrumental variables using genetics, a genetic risk score. In instrumental variables, we take advantage of instrument Z that is associated with exposure X. So the instrument Z must only be associated with the outcome through the exposure. So there's no direct effect of Z on Y. And the instrument must not be related to other factors that affect the outcome, such as W here in the figure. And if these assumptions are valid, a causal effect can be estimated from the data. As I mentioned, Mendelian randomization is merely a type of instrumental variable using genetics, and it takes advantage of the random assignment of an individual's genotype from his or her parental genotypes that occurs before conception. And this randomization by nature can be thought of as a randomized controlled trial and exploited to make causal inferences. For an example on Mendelian randomization, I'll walk you through a project which focused on obesity as a risk factor for multiple sclerosis, or MS. And previous studies had shown that obesity was a risk factor for MS. But as we know from Dr. Galea's presentation and Life Course research, obesity is very complicated. There could be other factors that associated with obesity and self-reported weight, which also are independent MS risk factors that could be confounding that relationship. So things like physical activity, diet, socioeconomic status. And so really a self-reported obesity in observational studies really could be a proxy for so many things. And so our goal was to use Mendelian randomization or genetic representation of obesity to measure the causal effect of BMI on MS. We constructed a BMI genetic risk score using 97 variants associated with BMI from a large external genome-wide association study. And the score is calculated by summing the risk alleles and multiplying them by their estimated effect on BMI, and then summing across all 97 variants to create a single weighted score. And as we heard in the previous presentation, this is across the population. So individual risk by person doesn't really represent much, but on a population level, we can look at the causal effect of obesity. And because there are such small differences for things like instrumental variables or Mendelian randomization, you really need a large sample size to be able to measure an effect. After all, a BMI genetic risk score only explains about 2% of someone's actual BMI. So it doesn't negate its power as an instrument, it just means you need a really big sample size. So in this study, we had over 6,000 cases and 15,000 controls using a data set from Kaiser Permanente, Northern California, and a secondary data set from Sweden. And we found that in both data sets, and then we went on to create a combined odds ratio, we saw that BMI was causally associated with multiple sclerosis susceptibility, which solidified that BMI itself plays a causal role on MS disease onset, apart from any downstream potential confounders. And I won't get into it here, but then we also constructed a childhood BMI genetic risk score to kind of try to tease apart adult versus childhood BMI. And while we found that childhood obesity was very strongly correlated with adult obesity, it was really that obesity later on in life that was significantly associated with MS risk. Beyond genetics, there are many types of instrumental variables that are used in research, especially with respect to local, state, and federal policies. And one can use these policies to look at factors such as social determinants of health. For example, literature has used state SNAP policies to look at food insecurity or travel distance or time to clinic for healthcare utilization, and changes in how co-payments are covered to look at medication adherence. And there are several other examples of instrumental variables to look at social determinants of health. So I encourage you to think about these types of analyses beyond genetics. So in conclusion, instrumental variables can be utilized to measure the causal effect of an exposure on an outcome using observational data by eliminating potential confounding. And there are many options for genetic and non-genetic instrument, but as I mentioned, they often require large sample sizes. And applying causal methods to big data can help inform mechanisms of disease, which will better inform treatments and interventions across the population. Next, let's discuss how machine learning can help us identify subgroups of disease and predict outcomes. Another hot term lately is machine learning. Quickly, as a review, machine learning is a subset of artificial intelligence in which computers have the ability to learn without explicitly being programmed to do so. And there are wide applications in health, although the longitudinal effectiveness in impacting outcomes remains to be seen. And there are two main branches of machine learning, supervised and unsupervised. Unsupervised is particularly useful for hypothesis generation, or perhaps when you don't have outcomes labeled. And today I'll talk about clustering specifically and how we've applied it to examine subgroups of disease. Distinguishing subtypes of disease is useful for treatment, prognosis, and understanding of disease biology. And there are many chronic diseases with a single diagnosis that actually may be representative of different subtypes of disease. And a great example is breast cancer, where tumor hormone receptor status represents a different genetic risk variance than other types of breast cancer, treatment responses, risk, and prognoses. And we can use something like clustering analysis when clinical and genetic complexity is suspected and heterogeneity of disease. And the goal is really to identify and refine definitions of subtypes based on clinical and genetic factors. And this is really a data-driven analysis and hypothesis generating. We use this technique to look at lupus specifically. So lupus is a disease with heterogeneous manifestations with a wide range of disease severity. And it's really difficult to predict long-term outcomes of patients and how they will respond to different medication. So our hope was to identify different patterns in the clinical and molecular data of these patients and identify distinct clusters, which we hope could lead to more refined and personalized treatment regimes. And at the time, no studies had integrated both genetic and clinical data from EHR to identify phenotypes using bioinformatic approaches. We took 400 patients with lupus that had both genetic data and electronic health record data. And then we extracted a genetic variance associated with lupus risk. And we combined that information with their EHR data, which included sociodemographic factors and some lupus-associated labs. And subtypes were determined using a special clustering method that accounted for the complex structure of our multi-ethnic data set. Usually genetic analyses are often restricted to one race or ethnicity due to heterogeneity, but in this method we could actually take advantage of our multi-ethnic data set because lupus is a disease that actually has a higher prevalence in non-white populations. And our clustering analysis found 3 distinct subtypes of lupus. And we also found some genetic variants that significantly interacted with the genotype cluster interactions after correction for multiple testing. So we found significant interaction with C3 lab, and also RNP positivity. Now, we used a similar approach for a different cohort of lupus patients, not from EHR data, but again, we clustered these subgroups based on clinical variables. And you can see, again, we found three clusters. So this ACR criteria is criteria for lupus and ethnicity, and you can imagine including all sorts of other factors. If you have a cohort study, it doesn't have to be restricted to any one type of variable. And then we correlated these clusters with methylation differences and found that there were different methylated sites found between these three groups. And we were also able to validate this in a separate set of lupus cases. So this is just a great example of combining multidimensional data sets and to make something more meaningful. And our hope is to take this down the road to look at different treatment responses between these groups. So in this example, we showed the potential for merging different types of data and using machine learning approaches. And as we move toward collecting social determinants of health in the EHR, which we're beginning to do at certain local sites, hopefully that becomes implemented nationally, these variables could also be incorporated into the machine learning models to understand more nuances of disease. And my hope is that these will help in identifying disease treatments for patients. Finally, I'm going to spend a little time discussing potential biases inherent in the different data sets and the importance in recognizing them. So while machine learning is exciting and has great potential to improve health, we also have to be conscious of its limitations. In machine learning or any data analysis, it's important to think about the source of the data and the potential biases inherent in it. And I think this came up in a question from the last presentation. And it may seem obvious, but in the world of machine learning, a lot of people think that data is data and more is better. But this can actually amplify biases. And I'm really interested in different sources of biases in data, particularly within EHR records. In order to look at disease at the population level, it's essential to include a study sample representative of the target population. And we learn this in basic epidemiology, but we know this is realistically not always possible. So in this study, we aim to compare longitudinal disease activity between participants in a cohort study and people who elected not to participate, because we had data routinely collected from all of them in a local EHR. And this was specifically in a population of patients with rheumatoid arthritis. And we found substantial differences in longitudinal disease activity between cohort research participants and non-participants, specifically racial ethnic disparities and RA disease activity over time present in non-participants were seen when you look at if you can see my mouse, when you look at all participants together, but if you looked at just the cohort alone, you could see drastic differences. So we don't see that higher disease activity associated with these different racial groups. So we wondered then if we could correct for these differences since we had information on who the non-participants are. So there are weighting methods such as inverse probability weighting or IPW that have been used to account for non-response bias, relying on correct specification of the selection model. When we attempted to use IPW to adjust for these differences between research participants and non-participants, we found that this was still insufficient to capture the large differences in disease activity by race ethnicity, largely among Black and Latino Hispanic patients. So in the third and fourth columns, you can see here that we're actually moving in the opposite direction that we saw within all participants. And so it really wasn't correcting. And we tried two different corrections. We inverse probability weighted using age, sex, race, ethnicity, disease activity, smoking status, BMI, language, rheumatic disease medication, and total number of visits. Basically, all structured data that we could get our hands on from the EHR. And then in weighted 2 example, the last column, we corrected, in our model, we attempted to correct for everything in weighted 1 and also the proportion of no-show visits, which we thought might be a proxy for likely external social circumstances that might prevent engagement of care, but this had little effect. And so our conclusion was that there are likely additional factors that are not captured in the EHR that explain differences in disease activity between those who participate in a study and those who do not, such as adherence to medications, social determinants of health, things that we couldn't include in the model and are generally not routinely collected in structured EHR fields. Locally at UCSF, we've implemented some changes where we will begin to collect some of these factors in the EHR, and it will be interesting to incorporate them into looking at these 2 groups down the road. An EHR may have advantages over cohort studies, as I just showed, but they're also not immune to biases. After all, they weren't designed for research. The EHR was built for billing purposes. And so we always have to think about the observed and the unobserved people and data in different study designs. For example, even when the EHR may represent a more real-world population than a cohort study, there are still potential biases inherent in the data. And given recent interest in applying machine learning to EHR data, in this paper, we explored how these algorithms may actually be subject to bias when applied to the data blindly and potentially perpetuate health disparities. And I'll just quickly walk you through this piece. So we discussed 3 major sources of bias entering EHR data that could have an impact on machine learning algorithms. And it's important to remember that these biases are not unique to machine learning. They actually have an impact on all statistical types of statistical analyses. But today we'll talk about them in the context of machine learning. And they are missing data, sample size, and misclassification or measurement error. Missing data can be thought of as missing individuals in the data set, as well as missing values for individuals in the data set. And machine learning itself cannot assign an outcome to individuals it does not observe, which can really limit generalizability of these algorithms. For example, models trained at an academic center may not directly translate to a community hospital, relating to designing interventions for a population versus a specific group. So we can get erroneous inferences if we try to apply something that was made in one setting and attempt to implement it in a different setting. So for example, patients with lower health literacy may not be able to access online patient portals and document their patient-reported outcomes. And so an algorithm developed to predict patient-reported outcome measures, which tend to be documented by those with higher income, younger age, and white race, may not benefit low-income, minority, or older individuals. Insufficient sample sizes may also lead to erroneous inferences. So models can underestimate values in low sample size categories. So machine learning algorithms will provide mean estimates for these groups to avoid overfitting. And this could result in uninformative predictions for certain subgroups. And therefore, algorithmic benefit may be restricted to larger groups, spurring improvements in certain patient populations without similar support for others. An example of this is when low sample sizes in certain subgroups may be misinterpreted as having a lower disease burden. So we know from the literature that Hispanic children are less likely to receive mental health treatment compared to white and Black children, despite a similar incidence rate. And it would be incorrect for a model to learn that Hispanic children do not benefit from mental health treatment and thus not recommend interventions. So we really have to think about the biases built into these data sets and therefore what the model is going to learn from them. Lastly, with misclassification or measurement error, this can occur with incorrect diagnoses in the EHR, records incorrectly coded, or incorrect patient recall. An example would be uninsured patients receiving substandard medical care more frequently than those with insurance. And so documentation or clinical reasoning will be less accurate or systematically different for those groups. An algorithm may be inaccurate for these uninsured patients and less likely to benefit them just based on this biased input. To wrap up, machine learning is powerful, especially when we have a lot of longitudinal data for prediction and classification. And they're helpful for generating hypotheses, identifying otherwise unknown relationships between variables, and especially when we have different genetic and sociodemographic and clinical variables from the EHR. But they're still subject to statistical bias present in other types of study designs, as well as human biases. And then I'll also add that until social determinants of health are systematically captured in the EHR, we will be missing a significant component in predicting and estimating disease processes. To summarize, today we discussed high-dimensional data and corresponding statistical methods and how they're not immune to bias, and that detailed attention to an acknowledgement of these limitations is really important. And lastly, again, inclusion of factors such as social determinants of health are really essential in understanding complexity of disease. Thank you so much.
Thank you, Dr. Gianfrancesco. That was an absolutely wonderful presentation and fit very well with Dr. Galea's. I really appreciated you talking about the biases that may happen with big data. I know often I hear, well, we have a lot of data, so we don't need to be worried about those types of selection biases or other things, or we can correct it with something like propensity score weighting and we're good to go. So I appreciate you touching on those points, and you gave some great examples about how that doesn't always fix the problem. So thank you. There are a few questions in the chat, and we have about 5 minutes left, so I'm going to turn it over to Dr. Ramsey and let her ask those questions.
All right, so yeah, we should have time for a couple. So first off is thinking about EHR research from a life course perspective. Do you have recommendations for including time when taking a machine learning approach to health research?
There certainly are different methods that account for time, particularly deep learning methods such as recurrent neural networks, where you can take an individual's entire course of the disease process and learn from that and compare it with others. I'm not strongly familiar with other types of methods, machine learning methods that do that. I've just seen a lot of deep learning. And I think it is really important if you can think about not only life course, but maybe someone's hospital stay. There are a lot of changes that happen during that time. And so time is a very important factor in accounting for what happens right before, and these recurrent neural networks really do that. So I would direct you to that type of research in the fields for those type of methods.
Thank you. So the next question is, what process would you recommend to assess what data sets can answer and what they can't due to their limitations? It would be important to start with clear identification of these constraints before research questions are posed.
Absolutely, and it's great that this person actually was great enough to acknowledge that we need to ask these questions before we even get started, not after. So what's been really helpful for me as an epidemiologist is to sit down with clinicians, sit down with a group that's really well-rounded. So clinicians, maybe the informatics specialist at the medical center, to really understand how data are being input. For an example, we were doing a project looking at lupus nephritis, which is a really serious outcome in patients with lupus. And there is an ICD code for this, but until we sat down with the clinicians, we didn't realize that nobody uses this ICD code, at least at this institution. So if we didn't have that conversation and we just kind of went in and looked at, a prediction model for who develops lupus nephritis, we would have been eliminating a huge portion of the population that had this outcome, but they simply weren't coded. So I think including clinicians to understand how data are input, including the informatics experts at your center to understand the back end of what goes on. When labs appear abnormal, there are different cutoffs, and so that could be important to your research question. So having a well-rounded group before you get started, I think just makes you ask the right questions and leads to a better research product in the end.
Thank you. So I think we have time for one last question. So it is, thank you for showing us how instrumental variables can be used for causal inference. How do we reconcile that population findings do not equate to individuals, and yet population health findings are used to guide our individual treatments?
Well, I mean, I think when you have something like a genetic risk score, let's take the obesity example, and we find that obesity is causally associated with something like MS, and you can imagine other chronic diseases as well. I don't think it negates the fact that obesity is a risk factor. We can interpret that to an individual with their genetic risk score, that they're more likely to have the outcome given their status, obesity status, but we can't guarantee that. And if anyone's done a 23andMe genetic analysis, we see that that's true for a lot of these genetic conditions where your probability is higher, but we can't say absolutely that this person will get this outcome based on the background. I think it helps us interpret population interventions that are needed. So I think reducing obesity in the population can have an impact on MS incidence as well as other different diseases. And so the message for the population level is still valid and can help reduce disease. It's just that individual interpretation where we can't say absolutely for sure that, you know, this person is absolutely likely to have the outcome based on their genetics. So I think it's a little back and forth.
Perfect, thank you. And that is all the time we have for questions. So I'll turn it back over to Dr. Hansen.
Thank you. And I would like to thank Dr. Galea and Dr. Gianfrancesco one more time for their wonderful presentations. It was another exciting webinar. Thank you very much for your thoughtful answers to the questions as well. I wanted to remind everybody that our upcoming webinar for October 15th will be held at 11 o'clock Eastern Standard Time. The topic of that webinar will be promoting and applying existing methods that fit a complexity science methodological framework. And we have two speakers during that webinar, Dr. John Jackson from Johns Hopkins. He will be talking about the integration of social epidemiology and causal methods, and Dr. Rock Nyango, who will be talking about microsimulation analyses and epidemiological research. So it should be another fantastic seminar. And again, thank you very much. We look forward to seeing you again soon.